sepsis, sofas, and acidosis on this episode of EM Unplugged podcast. Let's go, baby. All right, everybody. Hey, welcome to the EM Unplugged podcast. I'm Charlie Swearingen. I'm going to walk you through this. We got Greg giving a great lecture today on sepsis. And so let's go ahead and not critique it, but let's just go through it. Let's dig a little deeper. It's actually a longer of a video. It's 10 minutes. So we're going to break it down. Let's get started.
All right, let's break this down. Sepsis. And for those of you who keep saying you wish you could get CEUs for these, stay tuned until the end of the video. You're going to get your wish.
So here we go, like a little wink at the end too. So here we go. If you are enjoying this video and you want to get CEs out of it, the link will be in the description of the video. It goes to a website where all you got to do is sign up for an easy, quick account so that we can give you CEs and access to the online classroom. And there's a handful that'll be free to get your whistle wet, so to speak. And then once they will be paid for at some point in the future. So, they'll be $2, $4, or $6 each, or you could buy bundles. But in the long run, you'll be able to go onto our learning management system powered by MediPros.com, and essentially you've already seen the video. You just go through and take the quiz. You do well on the quiz, and the quiz is different. It's video questions. So it's me or Greg, or sometimes we'll have guests on where they'll be asking you questions. You make your answer selection. If you get it right, then you go on to the next question. If you get it wrong, then you get a tiny little couple minute long lecture on that content. Pretty simple, pretty easy, but way different. Nobody's doing this. We're the only ones, and copycats will follow, but that's okay. That's a form of flattery. And in the end, you get a tailored approach to your knowledge on this content. So if you get stuff wrong, you get a little bit extra lecture. In the end, you get one CE, 1 credit hour out of it. And we're fired up to be able to give it to you. And so there's some will be shorter, so there'll be 0.5 of a credit of a CE, and some will be 1, but all depending on how we handle it. But it's going to be a fun, great new thing, and we're excited to do this. So without that further ado, let's get to the actual content of sepsis.
Let's start off with what it is. So sepsis used to be called blood poisoning. This is a rampant systemic response to an infection, but often this response is exaggerated. And for it to truly be sepsis, it has to come with organ dysfunction. Now, this organ dysfunction is usually caused by an increase in metabolic demand from.
So one of the main contingents here early on is, of course, that this sepsis is this big response to something. Typically, it's a infectious agent, typically a bacteria. It can be from other things, but this is where sepsis is unique in its pathophysiology in that it leads to and begins to destroy organs. It's part of the whole new way that we classify how to or the couple of things that we look for as clinicians to trigger us to begin treating a sepsis, and we'll get into that here shortly, but organ dysfunction. So it's this massive, exaggerated response, also pushed in part by the result of organ failure. So I'm gonna back this up just a hair.
The disease, but a decreased function is usually dysfunction. Now, this organ dysfunction is usually caused by an increase in metabolic demand from the disease, but a decreased ability to meet that demand. And that's usually due to circulation in the case of septic shock, which we'll circle.
So again, here, one of the important pieces that he brings up is when, once we have this exaggerated effort, which costs energy. It costs sugar and oxygen to make that happen. And at some distal point, the metabolic demands are not being met, meaning there's not enough sugar, not enough oxygen. Typically, it's because of oxygen, right? We eat every day, a couple times a day, to get sugar in our body, but we can store sugar. What we can't store is oxygen very well. And so that's why we have to breathe every few moments, because oxygen and sugar go together to metabolize. And that's the whole point of everything we do in emergency medicine, is to facilitate that union of oxygen and sugar so that metabolism happens efficiently, right? We remember that as aerobic metabolism. If we're not doing that, then anaerobic metabolism happens and creates a bunch of different acids. Our body can't, every range, all of our vital signs and our labs and everything, they have to be within range. And acid, if we have acidosis present, there's more acid than normal, then our systems don't do what they're supposed to do. Our heart doesn't pump very well. The liver doesn't remove toxins as well. And so some tissues are more sensitive to high acids or low acids than others. However, the whole point is, if we're not meeting the metabolic demand. The body says, I need oxygen, I need sugar. And of course it needs all the other stuff. I need oxygen, I need sugar, and water is the three biggest ones. And if we don't give it to, if we cannot provide that cellularly, if we can't get oxygen into a red blood cell, push it around to the tissues and let it offload, if we're not eating enough or have enough sugar in our body to do something with that oxygen, then we have a decrease in metabolic demand. Now, too often that decrease results in some form of not being able to deliver enough oxygen, i.e. perfusion. So when we get to septic shock, then that's a problem of essentially not only the signs of sepsis, but now also low blood pressure, to the point where that's even further compounding the body's ability to deliver oxygen. So very good point here. I'm gonna let him go for just a moment.
Go back to toward the end of the video. To keep things on an easily understandable level, your best bet is to think of the body's inflammatory response as going haywire. It's often very exaggerated. It doesn't have to be, but most of the time it is. There's also an increase in nitric oxide. This results in profound vasodilation. With some strains of bacteria, there's actually an increase in endotoxins, which are also vasodilators. Any way you slice it, the end result of letting this thing run wild is going to be hypotension. And that hypotension is going to cause the organ dysfunction. We need a certain mean arterial pressure. You have to have it.
So one of the main things that he just mentioned that we really need to make sure to put the forefront of our mind is that, that response is going haywire, right? And that leads to vasodilation. So one of the key tenets of septic shock is massive vasodilation. Septic shock actually is part of distributive shock. There's three main types of distributive shock. We have anaphylactic, where the histamine is the cause of vasodilation. So really, when we talk about distributive, for distributive, dilation, right? For vasodilation, D for dilation, D for distributive. That's really how the reasons why they go into distributive shock, which is just massive vasodilation leading to a drop in blood pressure. If you have a pipe with a certain amount of pressure, but you change that pipe out to a bigger pipe and you have the same amount of water in, you're going to have lower pressure. That's just the simple physics there, right? Okay. So anaphylactic is distributive shock due to vasodilation effects of histamine. Septic shock is vasodilation and leading to lower blood pressure due to the vasoactivity of endotoxins, which you mentioned. I'm not stealing his thunder. He's going to go off on this in a minute. And of course, neurogenic shock, we just have an insult to the sympathetic nervous system. From that point of injury down, it cannot tell our vasculature to squeeze, and therefore it goes the opposite. It vasodilates. So that's and our blood pressure drops from that, and that's neurogenic shock. So all three of those are part of the distributive shock. And that distributive shock, in this particular case, vasodilation due to the exotoxins that the bacteria produces. So they eat up sugar in our blood, and then they essentially poop. I said poop. And that poop is the excrement of these bacteria is really what causes a lot of the vasoactivity. On top of that, we also have nitric oxide, which he brings up and is rarely mentioned in a lot of this content. But yeah, we have nitric oxide that can also contribute to that vasodilation. And again, I think I said exotoxins, endotoxins, the result. And this leads to low blood pressure. And over time, low enough blood pressure can't deliver oxygen. And therefore, we start having some tissues that are damaged, and that leads to organ failure. And then one organ dying leads to another organ dying, multiple organ failure. So that's kind of the layout. So he's about to hit on the effects of the body and how everything likes to be in ranges, kind of like Goldilocks. So let's get him teed up for that.
Certain mean arterial pressure. You have to have it. In the end, your body demands three things of you. Everything must happen at a certain temperature, a certain pH, and a certain pressure. Sepsis will alter all three of these categories. And that's one of the things that makes it so deadly, especially if you don't apply aggressive and appropriate treatment. Now, because of this increase in nitric oxide and or endotoxins, the blood vessels are going to dilate, and you're going to begin seeing a decrease in preload. Get a decrease in preload, you're going to get a decrease in cardiac output. It's as simple as that. Heart cannot pump what blood does not come back to it readily. In the beginning stages of sepsis, this is going to result in tachycardia. Even if patients are on beta blockers, they can still be tachycardic. This entire situation is further complicated by something called increased vascular permeability. So your blood vessels are not exactly like pipes. They are built to exchange fluids. The ability to maintain that physiology rests on homeostasis, and without it, blood vessels become quote-unquote leaky. We see the same thing in other conditions such as anaphylaxis. So not only do we have less fluid returning to the heart to be put in circulation because of vasodilation, now some of that fluid is actually leaking out into the extracellular space and not in the circulation at all anymore. To make things even more fun, your patient is going to enter a state of acidosis, and this is going to cause a leftward shift in the oxyhemoglobin dissociation curve. Now, if you don't remember what that means off the top of your head, that's fine. Here's the basic breakdown of it. The hemoglobin is going to become much more attracted to oxygen. On the surface, that almost sounds like a good thing, until you realize that it's so attracted to the oxygen that it can circulate all it wants, and it doesn't want to give that oxygen to the tissues. Now we have a problem. This is also a good time to mention that you can't trust your pulse ox when your patient is in this metabolic state. Pulse oximetry measures bound hemoglobin. Bound to what? Who cares? Carbon monoxide? Sure. Bound to oxygen? Sure. Doesn't matter. It just measures bound hemoglobin. It does not measure perfusion. Keep that in mind when you're dealing with a septic patient. To make things even better, your red blood cells are going to enter a state that's sort of akin to stiff, and now they can't even carry oxygen as well as they would like to. So the red blood cells can't carry the oxygen the way they want to, and then what oxygen they carry, they won't really offload the way that they're supposed to. And all of this in an environment with a patient that is very hypotensive who doesn't have enough mean arterial pressure to maintain in-organ perfusion. And that is the root problem in septic shock. Of course, until
Okay, let me see what he says right after this.
we invent some futuristic tools, we have no ability to visualize everything that I just said while it actively happens in the human body. So we have to look for other signs that imply this is what's happening. There are a couple of sets of criteria.
Man, okay, so this is what I get all fired up about this guy, Shade Tree, because that was about 2.5 minutes of stuff, and I'm sitting here and I've reviewed all this content, right? And it still blows my hair back. Okay, so let me break down a little bit what he's talking about. First off, he does a really good job here of figuring out and describing a couple different things that we've learned like in a silo, but now he's putting them all together. The fact that he's talking about all of the different ranges of stuff, pH, pressure, temperature, and these are all things that can be applied to the patient. Now, we could change blood pressure by, giving fluids to increase preload. We can do vasoconstriction, vasoconstrictor suppressors, vasopressors to essentially change the afterload, increase it a tiny bit, which later gets more fluid actually back to the right side of the heart. So it actually also indirectly increases preload. And so more blood comes back and the heart can pump better. We can augment that. We also can change temperature. We can put a blanket on and we can turn it, the heat up a little bit if they're not getting cold or if they're getting too cold. The pH, we can change that a lot with the ventilator is one of the main things. So we can change these things, and he's telling us that everything's got to be in the right range. That's kind of what we do when we go off to go do management of a patient. A lot of times, if we don't know what's going on, and this goes for critical care or ground, or it doesn't matter, or folks in an outside hospital helping trying to take care of a septic patient, in the end, you might not know what's going on, but you can always guide by vital signs and begin to, if something's way out of range, like dangerously, we do something to correct it. Heart rate's 150, we change it. In the case of shock and hypotension potentially, then okay, if our blood pressure is low, then we need to fix it. We need to give the right thing. In the case of septic shock, a lot of times they're dehydrated because, again, you need oxygen, sugar, and water to run all of your metabolic cycles, so to speak, your citric acid cycle, your Krebs cycles, and or your Krebs cycles. Those are essentially the same. And in the end, so we give a lot of fluid. Does a couple things. It provides fluid to use to help run those Krebs cycles, as well as it increases preload. So we have more blood coming back to the right side of the heart. So he also says, fluid leaking out. Okay, so this is just a problem with the nitric oxide as well as the endotoxins that cause the blood vessels to dilate. And when they dilate, they don't just get bigger, there's like holes in them a little bit in between, and it's easier for stuff to leak in and out of. So we can have third spacing, which is where you lose a lot of your fluid, and we lose preload. Really, if fluid leaves the vasculature, then we're losing preload, because preload is the stuff that shows back up to the fluid that shows up by the right side of the heart, where the body can begin to pump it and get it going. If blood doesn't show up to the right side of the heart, then that preload's not there. Acidosis causes problems with oxyhemoglobin binding, and he really talks about the oxyhemoglobin dissociation curve, which I know is like a sleepy kind of a topic. However, everything we do affects that thing, and so if we have if first off, if we're cold, that's going to be a left shift. If we're hypoxic, that's going to be a left shift. If they're acidic, then it's going to be a right shift. So the acid actually pushes it over, but you don't want to let it be acidic, because then that'll worsen everything else. So what you want to do is to correct the acidosis while you're adjusting temperature, pressure, oxygen, and you're trying to push those things all back to normal, because the oxyhemoglobin dissociation curve, it's a living thing. As that oxygen gets into the bloodstream, and let's say that it's heading to the lungs, because we breathe in and out, we basically, like a fan, when you put a fan on, you get a little bit cooler because air's moving in and out. The temperature of the lungs is a tiny bit lower than the rest of the body, and therefore oxygen, when oxygen leaves the airways, across the alveolar capillary membrane, sits on that red blood cell. Because it's a little cooler there, that red blood cell wants to grab on and not let go of that oxygen. So then that oxygen is pushed around to the tissues where it's warmer, because they're doing a lot of metabolism. So it's a little warmer. That's where we generate our heat. And let's say it goes to a muscle cell. Well, it offloads into that tissue, offloads onto a cell, finds a mitochondria of that cell, and walks in and combines with sugar to make ATP, right? And that's how our metabolism is designed. And so we can, and when it gets, and specifically with the oxyhemoglobin dissociation curve part, as it gets to the muscle cell, the squeeze of the red blood cell for that oxygen begins to release, and that's why when it's a little warmer there, because there's more metabolism happening. So because when you metabolize, oxygen and sugar go together, heat, water, CO2, and energy, that ATP pop out. But the heat is what makes us warm. And so when the red blood cell is bound to that oxygen bound to that red blood cell, when it gets around to the warm distal tissues, it just releases it. All right, that's the Haldane of the Bohr effect, but I won't bore you. Sorry for the dad joke on any further there. But that's what he's talking about. And he does such a great job of merging that idea. And so things that we need to do is really just try to make to where, the oxyhemoglobin dissociation curve sits in the middle until it's a left shift when the red blood cell is at the lungs. It's a right shift slightly when it's in the tissues. And so the oxyhemoglobin dissociation curve actually, is a living being, where it's not being, it's a living thing, a living concept that happens where it's constantly shifting. And if you're really cold, then it doesn't shift too much to the right. It just stays on the left. The same thing if you're hypoxic, or if you have, low acidity, then it's all pushed to the left. If you have high acidity or high temperature, or high oxygen, then it's a push a little bit more to the right. So it lives and breathes, and the whole point here is it can, because sepsis causes this low blood pressure and acidity, then it affects the oxyhemoglobin dissociation curve. And everything we do in emergency medicine, everything is to facilitate oxygen to get into that tissue, that cell, that mitochondria, and normally metabolize, to make sure that we don't create a bunch more acid, which is what happens when we metabolize inappropriately. We go through anaerobic metabolism. Then we create a bunch of acid, and too much acid, like we've already mentioned, the cells don't work right. So that's the whole point, and that's the whole goal. And so pretty powerful that he puts all that in there. And so, that's ultimately, he's kind of just describing the effects on the body. Next, he's going to get into diagnosing criteria, which is this is the newer stuff. It's been around a good bit now, but this is how we can actually identify it.
I'm going to cover two of them. It's almost three, but it's like 2.5. It's two, and then the second one's altered. Here, let me explain. The first one is going to be SIRS or Sears. Now, Sears criteria was kind of the flagship for this. This is the first thing that everybody began broadly using to try to identify sepsis and septic shock criteria. It's very simple. There was a list of bad things, and you could pick any two. If your patient met any two of the following criteria, you considered them positive for SEERS. The first one was body temperature, fever or hypothermia, meaning if they had a body temperature greater than 100.4 or a body temperature below 96.8. That's 38 centigrade and 36 centigrade respectively for you metric guys. Another thing on the list for SEERS was heart rate. Any heart rate greater than 90 beats per minute. Why so low? Because a lot of people take beta blockers. Any respiratory rate greater than 20. Blood glucose above 138, and there was some argument about that one. I don't know if it really made it into the vast majority of SEERS criteria lists. And then, of course, altered mental status, which is left just like that. It's not specifically defined. So this was a decent way for looking for septic patients, but there was a shift away from it to SOFA criteria later. SOFA ended up being much more useful, but it was really only applicable in the ICU. You needed lab values to figure out SOFA. Unfortunately, in pre-hospital, we don't really have a lot of those. So they developed Q-SOFA. Now, SOFA stood for the Sequential Organ Failure Assessment, and Q-SOFA stood for Quick Sequential Organ Failure Assessment. It was applicable to EMS, and it's proven itself to be a valuable tool. Here are the criteria for Q-SOFA. First is tachypnea at a rate greater than 22 breaths per minute. The second is altered mental status, which is defined as a mental status less than or equal to a GCS of 14. And lastly, a systolic blood pressure of less than 100 millimeters of mercury. And if your patient hit any two out of these three, it was considered positive for the Q-SOFA criteria for sepsis. Now, as we wrap up the identification for criteria for sepsis, some of you are probably asking, why didn't he include white blood cell count? The reason for that is that most of the time we can't really check that in EMS, but for posterity, let's include it here. So generally in sepsis, you're looking for a grossly high amount of white blood cells, or you're looking for a very low amount of white blood cells, but not in the middle and not normal. Generally speaking, you're looking for leukocytosis, meaning high white blood cell counts at a rate of greater than 12,000, or leukocytopenia, a reduction in the amount of white blood cells less than 4,000. So anything greater than 12,000 or anything lower than 4,000 meets the SEERS criteria. Now, while these criteria are great, they do not alone make the diagnosis for sepsis. A good history and physical exam is paramount to any patient. So the two big things you're probably going to want to know is, one, where does sepsis come from? And two, who is at risk for it? By and large,
So he goes a very good job of explaining here the basics, tenets of Q-SOFA. So again, SOFA is the Sequential Organ Failure Assessment Score. It doesn't matter, or you can just remember SOFA. The idea is if you get 2 points, you qualify. Like they qualify as a septic patient, so to speak. So he made 3 different items on here. This is the Q-SOFA because again, the SOFA itself is a lot of criteria, and this all started. There used to be SERS criteria that you had met. And then from there, you were defined as sepsis. And then after that, there was a third category that was severe sepsis. And then the fourth category was septic shock. Well, not long after that, or a couple 10, 15 years ago, when they started coming out with these, now there's just 3. There's SERS criteria, which we call SOFA now. Everybody's kind of switched to calling it SOFA. So we have SOFA criteria. We have the presence of sepsis. And then we have the septic shock. So if you have just one element of the SERS criteria or in the Q-SOFA, then you have a finding of it, but you don't have enough to call it the next category of sepsis. If you have 2 of these 3 criteria that we'll talk about that he kind of mentioned, GCS, respiratory rate, and altered GCS, respiratory rate, and blood pressure. If you have 2 of those, then you do categorize yourself as sepsis. And then, of course, if you go further and you have signs of organ failure and hypotension, that is going to be septic shock. So those 3 categories, GCS, respiratory rate, and I might have said heart rate earlier. Anyway, it's GCS, respiratory rate, and blood pressure, systolic blood pressure. So the way that I kind of easily remember it is just 15, 20, and 100. 15, 20, and 100. So if it's less than 15, then that's 1 for GCS. GCS, so if they're confused at all, then that's 1. If their respiratory rate is bigger than 22, okay? So if it's 23 or above, then that qualifies for an adult, as an adult patient, clearly. That qualifies for sepsis. If their blood pressure is less than 100, then that qualifies them, or systolic blood pressure less than 100, that qualifies them as well. So it's 99 or below, then that qualifies. So you need 2 of those to be able to call them septic by the Q SOFA or the quick SOFA scoring. And that will get you, if you have the ability to give antibiotics. Some places out there on the ground are giving antibiotics. A lot of critical care groups are giving antibiotics the moment that they know that. And so that's really the trigger, and that's the point. He next discussed of course, just and I mentioned like the rollout of how it used to be. It used to be 4 categories: SIRS, sepsis, severe sepsis, septic shock. Now it's simpler, and we've just replaced SIRS with SOFA scoring. So there's SOFA identifications, and of course in the field, Q SOFA, way easier for us to use. Then if they have 2 of those elements in Q SOFA, or if you have the number of things you need in SOFA, that goes to, and it's still usually 2, then that pushes you into sepsis, and so you begin treating for sepsis, so antibiotics and that kind of thing. And then if they develop organ failure as well as hypotension, then you're septic shock. So pretty easy there. And he does bring up the white blood cell count, and anytime it's over 12,000, that your white blood cells are doing something. They're ramped up because they're going and attacking something, and so that's just good to know. And again, he does a good job here of pushing together. There's a lot of times, well, we don't need to know that. It's like, well, I get you can't do a whole lot with that, but knowing that the white blood cells go up in this case a lot of times can help give you, especially if you're going to get a transfer and maybe they didn't diagnose sepsis yet. Be like, hey man, they're white blood cells. Then you call your medical director potentially and get orders for antibiotics or something like that if it's a thing. And all you're doing is just being a good patient advocate, because this is one of the things that if we get on early, this is what all JACO and CAS and CAIMS, they all talk about, all these accrediting bodies. They want us to be treating these patients as early as possible if they qualify. So if they qualify, boom, now we can go treat them. So that was really good on that aspect. He's about to get into the causes and the at-risk population. So I'm going to roll this back just a hair. Let's see where we are.
Great. They do not alone make the diagnosis for sepsis. A good history and physical exam is paramount to any.
You made a good point about that. Make sure you do a good
probably going to want to know
physical exam.
1, where does sepsis come from, and 2, who is at risk for it? By and large, the largest amount of sepsis is going to be caused by bacteria. There are 3 main types of bacteria that are present in over half of all sepsis cases. One is E. coli. The next are Pseudomonas. The last one is my favorite and yours, Staphylococcus aureus. Now, virus, fungi, parasites, they can cause sepsis too. It's just not nearly as common. So who is it that gets infected with these organisms? Pneumonia makes up greater than 60% of all sepsis cases, with most of the rest of the cases being genitourinary and abdominal in nature. Fun fact, in the elderly, the genitourinary system is primarily responsible for most cases of sepsis. In other words, UTI. Most of the time, that's going to be E. coli. In up to a third of all cases, there is no source of infection that can be determined. This is one of the reasons for the early use of broad-spectrum antibiotics. Broad-spectrum antibiotics like cephalosporins often have some coverage on all of these organisms. And while it's definitely not good as a standalone therapy from beginning to end of treatment, it is a great kickstarter for a patient that really needs somebody to tamp down the bacterial activity. Now that we've identified the organisms, let's talk about who is most at risk for sepsis. The list is about what you would expect. The very old, the very young, the immunocompromised, anyone with an indwelling like a Foley catheter, anybody who recently had surgery or has had poorly managed diabetes is especially at risk. This list also includes things like pregnancy and dialysis patients, among other things. So we've identified our criteria, we've identified our history, we've identified that we have a patient that's in one of the populations that have been listed. How are we going to treat this?
One of the things I loved he just said is like folks that are uncontrolled diabetes. Let me just put this into perspective really quick. If you have uncontrolled diabetes, you have high sugars that are usually high because you have uncontrolled diabetes. What do you think bacteria eats? They eat sugar. So, controlling that will help reduce a person's likelihood of getting sepsis. And just a funny fact that a doc once shared with me, and I was like, gosh, that just makes so much sense. It's just simple. And a lot of times medicine can be really complicated, really hard, but a lot of times it's really simple once we figure it out. And okay, so he goes into here, the primary cause, again, like we talked about, by bacteria. Pseudomonas, Escherichia coli, or E. coli, and then Staphylococcus aureus, so staph. And then he even starts talking about like cephalosporins and broad spectrum antibiotics. And the moment that we meet those 2, Q-SOFA criteria, what we need to do with that is make sure that we're getting them access to broad spectrum antibiotics and follow your protocols. Do like the pathway that you have to do to get them that. But that's the next thing is get them antibiotics. And most notably, the key here is like just all we've done is all we're talking about is like an assessment here. We've done a assessment that a EMT basic can do. I mean, GCS, respiratory rate, and low blood pressure. EMT basic can do that. And so EMT basic then therefore is also in the sling with identifying this. And so, you have a patient that has a source of infection or they look sick, then you go through this process, and if they have two of these three major criteria, and in the regular SOFA criteria is not just these three. There's temperature, there's white blood cell count, there's lactate, there's all these elements. And the more that you have, the more strongly it supports the diagnosis of sepsis. But in the end, a QSOFA, EMT basic can do that, which is why we include this for EMT basic as well CEs, because in the end, no matter what, if you're the basic level or you're at the critical care level, or the advanced level in the middle, the whole point is we need to be treating our patients better. And this is an easy thing to identify. And if you think, well, maybe that's kind of hard to diagnose, like it's not if you pay attention and you know what you're looking for. And that's where we kind of stay on our edge. So I don't want to get too much on a lecture of that part. But, he does mention that there's almost anything can cause sepsis, but this is typically the big thing. And then he mentioned about the blood sugar and how that strongly contributes to the presence of sepsis. So get that under control. And that's important. The very young, the elderly, the immunocompromised, recent surgeries, diabetes, pregnant patients, dialysis patients, all these patients are at risk for greater sepsis. A lot of these, so the elderly and the very young, their immune systems are just weak. They're weaker than when you're when you're a young adult up through later years of life. If you're immunocompromised because you have an autoimmune disease or any reason, then you're not going to have the white blood cells to fight off an infection, and therefore the bacteria is going to run rampant. A lot of endotoxins are going to be created. You're going to potentially lead toward septic shock. Recent surgeries, you might have already had an antibiotic course and killed a bunch of your flora and fauna, and then therefore then you're essentially iatrogenically immunocompromised. So that could be a problem. And so if you kill weak bugs and the stronger bugs that, while they're not in big numbers, stick around, they eventually can multiply. And that's where we get different medications that are resistant to certain antibiotics, because we've basically just killed off the weak ones and let the strong ones prevail. The diabetes, like we mentioned, is just a bunch more sugar. Pregnant women have a bunch of stuff going on, including they can have gestational diabetes, and then dialysis patient, and there's just changing out blood. Was everything clean along the pathway? Because otherwise, you're introducing bacteria into the patient's blood. So all those populations are at risk for those reasons. Let's get into treatment.
In the hypotensive patient, the first step in management is probably going to be IV fluids. We know that this patient has a decreased amount of fluid to actually work with because the container is now wide open, so we're going to want to put something in there. 20 cc's per kilo of ideal body weight is a great place to start. What fluid should you use? Current research is showing that Ringer's is excellent for this. Many systems still use normal saline. Now, giving too much normal saline and even too much lactated Ringer's can result in hyperchloremic acidosis, but that is definitely a topic for another CEU on a different day.
Definitely.
One thing I want you to remember about that is this: if you stay within protocols, you're not going to run a high risk of inducing this type of metabolic acidosis. Now, if the initial fluid bolus doesn't work, and neither does the second one in most protocol systems, you're going to want to move to a pressor. The pressor of choice in sepsis and EMS is going to be norepinephrine. Dosages vary, so I will not include them here. Oxygen therapy is also a good thing to implement at the same time you're doing this. Once blood pressure has been stabilized, you're going to want to start thinking about treatment. This is the time to draw your labs and your blood cultures prior to the administration of antibiotics if you can, but do not delay administration of antibiotics just to get blood cultures. That means don't go to the hospital and let them draw cultures without giving antibiotics. Go ahead and give the antibiotics. That's the standard of care. Monitor your patient's urine output if possible, or get a good history of what kind of urine output they've had over the previous days. This can be a great indicator to the physician of exactly how far along this patient is in this process, and it gives them a gauge of perhaps how aggressive they need to be in the next steps of the therapy that they will administer. All in all, your main goal in sepsis is you want to maintain a mean arterial pressure of about 65 millimeters of mercury and adequate oxygenation. If you can do these two things and keep organ function up to at least an acceptable level while you transport the patient, they stand a much greater chance of survival. The early administration of antibiotics also impacts this a great deal. So if you don't take anything else away from this, remember these two things. Memorize your sepsis criteria, memorize your protocols for correcting septic shock-induced hypotension, and hang a broad-spectrum antibiotic on the way to the hospital. That about wraps up the down and dirty on sepsis. All right.
So as we wrap this up, so IV fluids is very, very key. You're probably not going to give too much IV fluids. He did mention hyperchloremic metabolic acidosis, which, if you give too much normal saline, then sodium chloride, which makes up normal saline chloride, you can basically build up your the amount of chloride in your body, and then that's hyperchloremic. It's too much chloride, metabolic acidosis. So a lot of times you'll do 1 or 2 boluses of normal saline and switch to lactated ringers, which just has a bigger spread of everything as opposed to just sodium and chloride. It's got a little mix of everything, so you can give a bunch without like really sending one particular mineral over the top. That's kind of the goal there. And you might ask yourself, why don't we just give lactated ringers to everybody? Well, I mean, that's for another topic, another time. But nonetheless, 1, 2, or 3 fluid boluses. And as you're thinking about giving your third, he's right. We need to give a pressor at that point. If you give 1 or 2 fluid boluses, then you fill the tank, and we always have to fill the tank before we give a pressor. The other endpoint on the other side was if you give one, let's say they're a patient that has heart problems also, or has CHF. You give 1 liter of fluid, they start having evidence of fluid in the lungs. They have a shark fin waveform on capnography, or you hear rails starting to develop. Okay, at that point, we can talk all day long with septic patients typically need 1, 2, or 3 liters, or 1, 2, or 3 fluid boluses. If you give 1 and you fluid overload them, okay, no worries. I mean, you need to try to at that point do what you can to help them make sure they can continue to breathe, or intubate them and turn up the PEEP. But the biggest thing after that is to the moment at which they start showing signs of fluid overload, you just go to a pressor then, because at that point that you have a full tank. So 1, 2, or 3 fluid boluses. On that third one, we're thinking about a pressor, norepinephrine. This varies in the range of dosing, and it can be given either mics per minute or mics per kilo per minute. If you do a mics per minute, typically an easy one is similar to doing a infusion of epi. It's like 1 to 10 mics per minute. If you're going to do a range by weight, then typically it's like somewhere in the magnitude of 0.01 mics per kilo per minute up to 2 mics per minute, and 2 mics per kilos per minute, something like that. That's a lot though. That's a huge range if you think of it, and how many times that decimal moves over. So a lot of places will do like a 0.01 to 1. And so when you get to the 2 mics per kilo per minute, that's a lot. It's a lot. But I mean, again, follow your protocols, your area. Those are just common things. And then things that I'll do is I'll put it at like 5. Like if I'm doing norepinephrine, a drip, and I'm just going to do mics per minute, this is an adult, let's say, then I'm going to put it at 2.5 mics per minute. And the reason I do that is so I just look over at the pump next time I need to use it, and we can double that and go to 5. You double that, you go to 10. And so you kind of quickly get up to, towards the upper end of that range just by simply doubling. It just kind of makes sense for me, but do what you got to do. Oxygen therapy, of course, we need to make sure that we're ventilating to help clear out CO2 as well as oxygenating. So on the vent, if they're on the mechanical ventilator, make sure that they're getting, high FO2s, high PEEPs, if needed to get oxygen to them. Increasing rate will not increase the oxygenation unless you're at 21% oxygen, because the moment you start adding more oxygen into like a higher fraction of oxygen per breath, you limit the limiting factor isn't the respiratory rate, it's how fast it can get across that alveolar capillary membrane, and PEEP and then a percentage of oxygen do that. So a little nugget there. Labs, blood cultures, antibiotics. So antibiotics need to go in as fast as possible. The door to antibiotic time has been pushed to be as short as possible. So if you don't have the ability to take cultures, but you do have an antibiotic, and so let's say you're a ground ambulance and you have antibiotics. Let's say you have, whatever, and you have the ability to give the antibiotic, you give the antibiotic. You don't wait. If you don't have cultures to take, then you don't wait. You give it, right? So even though it's gonna screw that ability to know exactly what bug it is, there's still ways we can do it, and you want to get that antibiotic in ASAP is the point. The monitoring urine output, great. Okay, so 0.5 to 1 mil per kilo per hour. So 0.5 mil to 1, 0.5 to 1 mil per kilo per hour is the urine output. So if let's say somebody is 100 kilos, well, half of that, which is 0.5, 50 kilos, i.e. in this case 50 mils, should be in that Foley bag every hour. And so then you can half that again. 25 mils should be in that Foley bag every 30 minutes. And so quick little easy calculations like that can help tell you, because you might be with somebody for 15 minutes. If they have a Foley, you empty it, you roll, and like 15 minutes later you look down and you say, oh man, there's only 10 mils in there. Okay, well that should be, at least if it's a 100 kilo patient, half of that for the hour should be 50 mils, half of that should be 25 mils. So in 30 minutes, and let's say that you have, half of 25 is 12.5. So the point there is, like, if there's only 10 mils in there, there's not enough. And so we need to give another fluid bolus is the point there. And people say, well, you might not have them. I mean, like, you might not have your transports might be 5 or 10 minutes. I get it, but typically you're with a patient a little bit longer than that. The lead time. So as you walk into a room, one of the first things I'll do is to empty that Foley if they have a Foley, especially if it's potential sepsis. And like you said, UTIs in the elderly, that is a horrible source of infection, and so therefore a source of sepsis. So dumping the Foley bag and then clocking the time. I hit my watch 30 minutes, and 30 minutes later, because usually it takes 5 or 10 minutes to get them ready, then 5 or 10 minutes to get down to the transport vehicle, 5 or 10 minute transport. Well, at that point, you're at 30 minutes, right? And now you could tell them, like, hey, they're only produced 10 mils in the last 30 minutes. And I was very diligent to watch. So the point there is do what you got to do to give them good info, and urine output is such a big thing, and not only burns and sepsis, it's good all the way around. It's a good way to identify if your patient has enough fluid. Okay, and the main goal of MAP of 65 is just a good nugget for most everybody. The get MAP by so systolic and diastolic. So it's basically you double the diastolic and add to the systolic. So, and then you double the diastolic, you add to the systolic, and you divide by 3. Okay, and so that gets you your MAP. Also, on most monitors now calculates MAP. So you want to, if you've given a fluid bolus and the MAP is 60, and you're like, hypotension will worsen acidosis, will worsen oxygen delivery. So at that point, even if you've given 2 or 3 liters, like, well, it's not that bad. So, but it is if it's not 65. So at that point, put on a low dose pressor. Put on a low dose norepi. If you don't have that, do epi or dopamine, something, whatever's in your protocol, whatever makes sense. But in the end, like, get the pressure up. Okay. And then he's going to wrap up here, and I'll let him do this, but pretty cool.
Get out there and practice. All right. If you're still here because you're wondering about the CEUs, stay tuned. Next week, this video and many more will be available for CEU content. We will publish the... All right, let's break this down. Sepsis.
All right, so that kind of cut off. But in the end, we're doing these where we either do a lecture in some form. I will steal a bunch of his TikToks and just go through and do the lecture on it and use it as our podcast. We'll have guests on occasion. We'll do some special events where we'll actually be located somewhere. The Chive Charities is going to be a place, or the Chive itself in Austin, Texas, is going to be somewhere where we've recorded before. We'll be back again as a board member of the Chive Charities. I get that ability, and then we'll, of course, shuttle some money to the Chive Charities, which is just a great way to give back. So all that said, if you're looking for CEs, click in the description, and there'll be a link to CEs, and you'll be sent to our website where you can sign up an account and pay for again, a handful of these will be for free, but then you'll be able to pay for if it's one that you pay for, you simply pay $2, $4, or $6 depending on the level of CE, and that's really just for EMTs basics, or EMTs, paramedics, nurses, critical care medics, and so on and so forth. And that gets kind of gray, but the CE will just be a price, and you can pay for that. You can also later, we'll have bundles as we build more and more of these, but please let us know in the comments what you think. He's got some great comments here, actually. this first one, and we know this guy, he's a buddy of ours. I'm bringing sepsis back. It's vasoactive shock, and that's a fact. It makes your BC drop. It's just funny, man. That's good stuff. I had sepsis when I was 18, almost died. To this day, the doctors have no clue why it happened. They chalked it up to cysts exploding my pelvis. Yuck. Wow, that sucks. Well, sorry, little Miss Hoglet. It's funny. It's a cool name. But the things happen, and we don't know why. But the whole thing is we need to go look for those cue SOFA signs and make sure that we are managing it. So somebody brings up all these different questions. That's funny. VL or DL, straight or curved. Yeah. So this is somebody who just appreciates Shade Tree's deep knowledge of stuff. The clock back there said 333 at one point. Looked like EEE because it was, of course, backwards. Messes people up. Yeah, this is a ICU nurse. And in the ICU, a patient showed symptoms. We draw lactic acid. If it came back elevated, we're doing sepsis. And that's because the idea of if sepsis is present and we have that vasodilation and it drops blood pressure, therefore drops perfusion out at the distal tissues, then at those distal tissues, they're not doing oxygen and sugar together normally, which is aerobic metabolism, probably going through some anaerobic metabolism, leading to an increase in acids, including lactic acid or lactate. And as that elevates, they assume, well, the worst of all evils is going to be sepsis. So it might not be, the lactate is not the end all be all, but what they're using that as a trigger to start sepsis treatment. Not necessarily the full diagnosis criteria, but that's a good thing that people have done and will do. And that's why a lot of times you'll see studies that report that lactate, can vary. And but it's the sensitivity and specificity. And I'll do a video where we kind of go into that so people can understand research and that kind of thing a little bit better. But in the end, even though it's not the end all be all, if lactate is not the end all be all for identifying sepsis, it's still a pretty good one. Yeah, so this person, Chad, said, sadly, I have no pre-hospital antibiotics, and the only pressor I have is dopamine. Not to mention, we use SIRS criteria alone. So if this is for Chad, you and anybody that fits this is their type of situation that they're working with, where they operate. You could still use the other criteria, and you could look for SIRS, which is SIRS technically, but I can't spell very good either, dude. But the point here is that use what you can. I mean, if you it's pretty easy to assess that they're potentially having sepsis or septic shock. At that point, I'd use your dopamine. It's not it's not probably the best medicine, but it's a pressor, and at that point you can use what you have. And not having antibiotics, no problem. But just in your radio call, say, hey, they meet SIRS criteria for you, or however you want. They appear septic. Be ready with antibiotics. You could patch that on so that they're kind of ready and they don't kind of wait too much. And so anyway, that's it, guys. Thanks for joining us. Hopefully you enjoyed this and it was helpful. I mean, it always helps me as an educator to go through and do great, or try to build great content so that people can use it. And so myself, I go back and look at these. And again, there's so much that we're learning on social medias now. There's so many great content educators and creators out there doing really, really good stuff. It's not going to be just me and Greg here. We will do other folks and bring other guests on and that kind of thing. That's going to be the goal. But overall, man, I hope you've learned a lot from sepsis. I hope you really consider doing the CEs and going on, and it'll take you another 10 minutes to do the test. And they're video questions. So once you're done, you get your CE immediately and good to go. You'll be waiting around for the next one next week. But until then, take care, stay safe, stay salty out there, and we'll see you next time.